and bile I'll cover up in the next lecture. So starting off, now as far as the exocrine pancreas is concerned, now when the chyme, that is basically the gastric contents, they have been acted upon by the gastric juice, and there would be a regulated gastric emptying which would occur. So as the chyme, it flows into the small intestine. You know that in the gastric uh, juice, it's highly acidic, right? So as the acidic chyme is going to flow into the small intestine, the acidity has to be neutralized. Otherwise, what will happen is it is going to damage the duodenal mucosa, right? And second thing is that in the stomach, not much digestion has occurred. So still the nutrients are in the form of macromolecules. So they further need to be digested in order to get absorbed, right? So what happens is that the exocrine pancreas, it plays a vital role in accomplishing both the objectives. What are the objectives? Objectives are that the acid should be the acidic chyme. The chyme which is acidic in nature has to be neutralized, and it can be neutralized if you are going to buffer it, or buffering kaise hogi? By bicarbonate ion. And bicarbonate ion kahan se aayega? It would be secreted by the pancreas, right? Second thing which should happen, as I told you, is that the macromolecular nutrients have to be broken down much further. So the pancreas is going to supply a lot of enzymes which are going to help in the digestion of the nutrients, right? So most of our digestive enzymes, they are coming from the pancreas. What will happen if our exocrine pancreas do not function properly or it is diseased, right? So endocrine pancreas agar nahi function kar raha, endocrine mates is basically secreting the insulin, the glucagon, the pancreatic polypeptide and the somatostatin, right? So agar unki kisi ki deficiency hogi, they will lead to deficiency disorders of the endocrine pancreas. But what happens if apart from the endocrine, the exocrine portion of the pancreas is damaged? Now, pancreas, the exocrine portion का safety factor बहुत high है. So it needs to be damaged almost 90% if the insufficiency has to occur, or if it is going to manifest itself in the form of symptoms. So this is a very difficult diagnosis to make as a physician, as a gastroenterologist, because why? What's happening is basically that these symptoms will mimic the symptoms of other GI disorders. So none of the physicians is going to think about the involvement of pancreas per se at the outset. Okay, so they would be making simpler diagnosis. They might go in for, they might just go in for a peptic ulcer diagnosis, or they could go in for the inflammatory bowel disease diagnosis. They will not go in for a pancreatic disorder. So, but by and large, anyways, it is important because इसमें involvement अगर हो जाता है तो इसकी mortality भी काफी होती है, so it has a mortality which can range from anything between 2 to 10%. So if a person suffers from pancreatitis, it can lead to pancreatic carcinoma, and then these are pretty fatal kind of diseases. So at your level, at this point of time, you should be familiar with these terms, that if the exocrine pancreas is not functioning properly or it is diseased, it leads to not functioning properly. It will be called as exocrine pancreatic insufficiency. Exocrine because we are dealing with the exocrine part, pancreatic because we are dealing with the pancreas, insufficiency because it is not functioning properly. तो जो भी pancreas के function होंगे वो नहीं हो रहे. So what can happen is the patient can complain of loss in weight, can complain of abdominal pain or flatulence and bloating, bowel changes. Bowel changes means can be it can be diarrhea, it can be constipation, deficiency in especially the fat soluble vitamins like vitamin K and D. So if these are deficient, you can see that vitamin K deficiency can lead to bruising, easy bruising or bleeding disorders. Vitamin D deficiency can lead to disorders of the bone, and it can also have electrolyte deficiency. Of course, there are other symptoms and signs which can be present in case. This is just by and large just an introduction part, right? So another disease is pancreatitis. As I told you, wherever the term itis comes, it is talking about the inflammation. So here it is the inflammation of the pancreas, which can be acute. When you say acute, acute means it has occurred suddenly. When you say chronic, chronic means that it is occurring over a longer period of time. So when you call any disorder as acute, it is acute means occurring at a very within a very short span or has occurred suddenly. Chronic is a long-standing disorder. So before we proceed further, let's start with a little bit of video. So I'll just show you a video. So this is a video on pancreatic exocrine insufficiency.
This is your pancreas. It has a job to release digestive enzymes when you eat, as food passes from your stomach to your bowels to help you digest it and absorb its nutrients. Some people have a condition in which their pancreas doesn't produce enough of these digestive enzymes. This is called pancreatic exocrine insufficiency, also referred to as PEI or EPI. If you have PEI, it can affect your quality of life, and if left untreated, can result in poor absorption of nutrients, leading eventually to malnutrition. PEI can develop as a result of a number of conditions and issues, including chronic pancreatitis, pancreatic cancer, and cystic fibrosis. It can also develop after surgery to your stomach, intestines, or pancreas. If you have PEI, you might experience symptoms such as abdominal discomfort and pain, gas and bloating, diarrhea, steatorrhea, greasy, foul-smelling floating stools, flatulence, and unexplained weight loss. PEI is confused quite often with some other GI conditions, such as peptic ulcers, Crohn's disease, celiac disease, lactose intolerance, and irritable bowel syndrome, since they cause many of the same symptoms. If you're experiencing some of these symptoms, it's important to speak to your doctor to determine whether you have PEI or another GI condition. Your doctor may arrange for one or more tests, including blood and stool tests, ultrasound examinations, and possibly a CT or MRI scan to confirm that you do have PEI and to ensure that you don't have another condition. How can you take control of your PEI? First up, PERTs. Your doctor may prescribe pancreatic enzyme replacement therapy, or PERT. PERTs have the power to break down your food so you can digest and absorb its nutrients, to be taken during your meal or snack. PERTs travel past your stomach with your food until they reach the small intestine, where they dissolve and release a mix of digestive enzymes. Lipase, to break down fat, proteases, trypsin, chymotrypsin, to break down protein, and amylase, to break down carbohydrates. Your doctor will determine the dose of PERTs that you'll need based on the severity of your symptoms and the amount of fat in your diet. Treatment doesn't stop there. Next up, adjust your diet and lifestyle to help manage your symptoms. Avoid meals or snacks that have a high fat content. With your doctor's guidance, adjust the amount of PERTs that you take to match the size of your meal or snack. Increase physical activity. Avoid alcohol unless your doctor feels that it's safe for you to take a small amount. And quit smoking. Your doctor might also prescribe fat-soluble vitamins like A, D, E, and K to replenish what your body can't absorb from your food. Together with your doctor, you should be able to come up with a treatment plan that works for you, so you can get back to living your life your way. This video was brought to you by Mylan. Find out more.
Okay, so that was just an introduction just to keep the ball rolling and to make you understand why pancreas is so important for us and why is it important to understand the physiological aspects of any disorder of the pancreas, right? So today the learning objectives or the key topics which I would be focusing on would be the functional anatomy of the pancreas, the functions of pancreas, the composition of pancreatic juice, how the secretion occurs, the applied aspect, and the pancreatic function test. Now, pancreatic function test, I think, is a part of your competency number 4.9. So I'm covering it here so that you have a better understanding of these tests. Okay. So this you must have read in your anatomy classes. This is just showing you the anatomical location of the pancreas. It lies behind the stomach and it is adjacent to the second part of the duodenum. It has a head, body and tail. It has uh, a main pancreatic duct, which is known as the duct of Wirsing, and it has an accessory pancreatic duct or the duct of Santorini. Now, this duct of Wirsing or the main pancreatic duct, it opens into the second part of duodenum. That part is known as guarded by the sphincter of Oddi, and it is dilated slightly, so it's known as ampulla of Vater, right? And of course, it is joined by the common bile duct. So the opening of the common bile duct and the main pancreatic duct, they are together. Now, as far as the physiology is concerned, for the physiology, I'm not going into much of the details of the anatomy part now. So as far as the functional, structural and functional physiology is concerned of the exocrine pancreas, you have the duct cells. These duct cells, they secrete sodium bicarbonate solution, and you have acinar cells which secrete the digestive enzymes. So pancreas is an accessory organ of digestion, or it is an accessory glandular organ of digestive system. This is a compound gland, just like your salivary gland. So this is a compound gland. It comprises of acini and it comprises of the ductal cells. The ductal cells, they secrete bicarbonate, and the acinar cells, they secrete an enzyme-rich fluid, right? So there are two parts which are concerned with it. If we go into the details of the morphology of the acini and the duct of the pancreas, right? So here you can see this is the main pancreatic duct. Then you have the interlobular duct. Interlobular ducts is going, the intralobular ducts, they form the interlobular ducts, and interlobular ducts, they combine to form the main pancreatic duct. This is showing you a lobule of the exocrine pancreas. It contains number of acini, and acini, they contain number of acinar cells. ठीक है? तो इसमें क्या हो गया, इसका आपका यूनिट आ गया. यूनिट इज द पैनक्रियाटिक acinar cell. Pancreatic 15 to about 100 pancreatic acinar cells, they are present in one acini. In between you have the intercalated ducts. So the secretion of the pancreatic acinar cell will flow into the intercalated ducts. These intercalated ducts will join and they will form the intralobular duct. Intralobular duct will go as the the interlobular duct, and interlobular ducts would form the main pancreatic duct. तो जैसे salivary secretion में you had a primary secretion and a secondary secretion. So here also there would be a primary secretion from the acinar cells, which would be modified on its passage to the duct, and in addition the ductal cells would be secreting a fluid which would be rich in bicarbonate ions, right? So this is showing you the pancreatic acini and duct morphology. The pancreatic acinar cells, as you can see here, it has a lot of endoplasmic reticulum, it has a lot of Golgi bodies, it has a lot of granules which are known as the zymogen granules. So this shows that this is probably involved in synthesis of proteins. And what are those proteins? Those proteins are basically the enzymes which are secreted by the pancreas, and those enzymes are, it has the lipolytic enzyme, it has the proteolytic enzyme, and it has the amylolytic enzyme. So by and large, it is helping in digestion of all the three nutrients, the major nutrients which we ingest. In contrast to this, if you see the ductal epithelial cell, you can see that the ductal epithelial cell has a lot of mitochondria. The endoplasmic, the rough endoplasmic reticulum and Golgi body are much less as compared to that of the pancreatic acinar cells. And of course, you can see that on the apical side, it has a lot of fold-like it has a lot of microvilli. So it's involved, mitochondria means that it is involved in secretion which requires a lot of energy. So this energy would be provided by the ATP, and this ATP will come from the mitochondria. So the exocrine pancreas, it has two main functions. It secretes pancreatic juice, which contains powerful enzymes required for digestion of food. So the enzymes which are present in the pancreatic juice, it includes lipases, which help in digestion of fats, amylase, which helps in digestion of carbohydrates, and then you have these proteolytic enzymes like chymotrypsin, carboxypeptidase, trypsin, which are helping in digesting proteins, as well as nucleases, which digest the nucleic acids. Another function of pancreas is that the pancreatic juice is highly alkaline, so it helps in neutralizing the gastric hydrochloric acid, which is present in the chyme which enters the duodenum. So here you can see that once the acidic chyme, it enters into the duodenum, then the duodenal cells would be, you have specialized cells which would be releasing hormones in the form of secretin and cholecystokinin. Now when you talk about hormone, the hormone has to go into the blood circulation, so it will go into the circulation and come back to the pancreas via the blood circulation and cause the release of an highly alkaline pancreatic juice. अगर फैट्स और प्रोटीन्स ज्यादा होंगी तो एंजाइमेटिक रिच जूस सिक्रीट होगा, और अगर एसिडिटी ज्यादा होगी तो उसमें बाइकार्बोनेट रिच would be secreted more. So it depends upon the contents which are being emptied into the duodenum from the stomach. And this is the reaction which occurs when the bicarbonate is neutralizing the acidic chyme. So the acidic chyme means the gastric acid is the HCl. When it combines with sodium carbonate, bicarbonate, it will form sodium chloride and carbonic acid. Carbon dioxide and water would be formed from it. So carbon dioxide would be exhaled out through the lungs, and water will flow out through the kidneys. And secretin is the nature's anti-acid, because when the duodenal contents, the acidity of the duodenal contents increases, they respond by secreting secretin from the S cells, and this secretin helps in inducing bicarbonate secretion from the pancreas. It functions in a negative food feedback loop mechanism. So as there is a decrease in pH in the duodenum, there are the S cells which are present in the duodenal mucosa. Their stimulation will occur. This S cell will cause the release of secretin, and this secretin in turn will stimulate the ducts of the pancreas to secrete the bicarbonate ion, and this bicarbonate ion will have a negative feedback. Now this has helped in neutralizing the acid, so it is going to inhibit the secretion of secretin. Do you know this? I've been known to digest myself. Now I here means pancreas, right? So exocrine pancreas is saying that it can digest itself. This strange phenomenon is known as pancreatitis, right? So if it is digesting itself, once it is digesting itself means it is hurting itself. Once it is hurting itself, it is setting up an inflammatory response, and once the inflammation occurs, it is known as pancreatitis. If it occurs suddenly, it is acute pancreatitis. If it occurs over a longer period of time, then it is known as chronic pancreatitis, right? Why does it happen? Because the pancreatic digestive enzymes, they become active while they are still within the pancreas, right? So normally what happens is once the pancreatic enzymes are secreted, they are all secreted in an inactive form, and they do not get activated within the pancreas itself. But if there is some insufficiency or due to some reason these enzymes become activated within the pancreas itself, they are going to damage itself. This is showing you that the enzymes are normally released into the duodenum, and these are in the precursor forms, or they are in the inactive forms. So they are activated within the duodenum. But अगर इसका कुछ obstruction है, or there is some disease within the pancreas, or there are some other reasons which are causing the activation of these enzymes within the pancreas itself, it will start injuring the acinar cells, it will start injuring the pancreas, and it leads to inflammation and damage to the acini. So this is causing basically ऑटो डाइजेशन. खुद ही सिक्रीट किया और खुद ही उसके ऊपर एक्शन हो गया, तो उसने अपने को डाइजेस्ट खुद कर लिया. So this is ऑटो डाइजेशन. So what helps the pancreas from auto digestion? What is preventing? Helps me, sorry, what is preventing the pancreas from auto digestion? There are several mechanisms that protect the pancreas from auto digestion. One is that it contains trypsin inhibitors, right? So these trypsin inhibitors, this family of inhibitors, it prevents the activation of the proform of trypsin and other secreted enzymes in the acini and ducts, right? So it will not let it activate within the pancreas itself. Second level of protection, it lies in the fact that trypsin can be degraded by other trypsin molecules, right? So once the trypsin is formed, it is going to degrade the trypsin itself, right? So again, it is offering protection that बहुत ज़्यादा stimulation ना हो पाए. So and third is that digestive proteins, they are stored in the secretory granules as inactive precursors or zymogens, right? So they are stored in the zymogen granules, which become activated only after entering the small intestine. So this is a very important question. You can get a question on explain what will happen and why if the enzymes are they are activated within the pancreas itself. So you should be knowing the physiological basis of auto digestion, that what is happening, what is preventing this auto digestion. Then we come on to the pancreatic juice, right? So you know the structure of pancreas. the morphology of the acini, morphology of the ductal cells. Then we talked about the functions of the pancreas. Then we talked about that pancreas can digest itself. And then we talked about how the autodigestion of pancreas is prevented, right? Now we come on to the main topic, that is the pancreatic juice, right? So before we go on to the secretion of the pancreatic juice, this is just giving you a few properties of pancreatic juice and the composition of pancreatic juice, right? So about 1200 to 1500 ml per day of pancreatic juice is secreted. It is highly alkaline, having a pH of 7.8 to 8.4 due to the presence of a high bicarbonate content, which is almost 4 to 5 times that of plasma levels, and it is transparent fluid which is isotonic with plasma. Composition: it contains water 99.5% and solids 0.5%. In solids, again, you can divide them into inorganic and organic. Organic are the enzymes, which include the proteolytic enzymes, which include the lipolytic enzymes, and which include the amylolytic enzymes. Now, as far as these enzymes are concerned, because you know that these enzymes are secreted in the pancreatic juice by the pancreas, in the pancreas are secreted by the acini. So if there is any insufficiency of the pancreas, or there is some disorder of pancreas which is suspected, then the serum levels of some of these enzymes can be tested. Although they do not have much of the diagnostic value, but still it can just give you an indication of whether the pancreas are involved or not. So the serum amylase level, the lipase level, and trypsin, chymotrypsin are also sometimes done. Okay. Other organic substances which are present in traces here are the albumin and globulin, and you have inorganic substances in which are already listed here. So activation of proteolytic enzymes, as I stated that the enzymes, they are secreted in the pro forms, they are not in the active forms. So the proteolytic enzymes, they are all secreted in the pro form. So you have the trypsin, which is secreted as trypsinogen, chymotrypsin, which is secreted as chymotrypsinogen. Then, of course, you have the carboxypeptidase, nuclease, elastase, collagenase. So all these enzymes, they are secreted in their pro forms. How they are activated? Once they are in the small intestine, the small intestinal mucosa, it secretes the enzyme, that is enterokinase, and this enterokinase helps in catalyzing the activation of all the trypsinogen to trypsin. And as I told you, trypsin itself can cause inhibition of further trypsin molecules. So this is just showing you that. Now this, once the trypsinogen has become activated into trypsin, it further catalyzes the activation of other proteolytic enzymes. So trypsin has an autocatalytic activation, and it can activate other protein enzymes also. So this is this you must have already covered in your biochemistry also. It's just showing you the digestion which is occurring by means of various pancreatic enzymes. So trypsin, chymotrypsin, they cleave the proteins to polypeptides. Carboxypeptidase cleaves the polypeptides to amino acids. For carbohydrate digestion, you have amylase, which causes the digestion of starches and glycogen to disaccharides. All the enzymes, they are secreted in excess, and they must be reduced to 10 to 15% of normal to cause problem. Amylase is the only luminal enzyme for carbohydrate digestion. Pancreatic lipase, phospholipase, and cholesterol esterase, these are enzymes for fat digestion. and going a little bit fast here because ये फिर आपको again digestion and absorption में we'll come back to this again, and this is just a repetition. You must have read these things in your school times also, and biochemistry people must have also told you about these. Right, now we come on to the secretion of the pancreatic juice. Right, so in the pancreatic juice, as I told you, it contains the organic contents, it contains the inorganic contents, and it contains the water. Right, so you have water and solids. In solids we have the enzymes. So in the enzymes, the secretion of pancreatic enzymes will occur in the acinar cells, right? So secretion of pancreatic enzymes, it occurs in the acinar cells. Now in the acinar cells, if you see here, this is showing you a pancreatic acinar cell. So here you have the rough endoplasmic reticulum, Golgi body, condensing vacuoles, and zymogen granules. आपने protein synthesis आपका हुआ होगा, right? So in the protein synthesis, you know that proteins, they synthesized, the synthesis begins from in the nucleus, right? You have the transcription, you have the post-transcription modification, then you have translation, post-translational modifications, and they come out on the rough endoplasmic reticulum, from where they are modified. The post-translational modifications, they occur within the Golgi body, and from the Golgi body they can be secreted by the constitutive pathway or the regulated pathway, right? ये सब आपका already you must be familiar with these things. So once in the Golgi body, they are organized into vacuoles where the enzymes would be separated from the enzymes of the lysosomes. So they would go into the lysosomes, the pancreatic enzymes will come into the zymogen granule, and when the signal arises, the zymogen granules are going to release the enzymes by means of exocytosis. कैसे prove होता है? Prove होता है, like experiments have been done which have shown that the pancreatic enzyme secretion occurs by this mechanism. By means of what they did was injected the radioactive, the radio labeled grains, and here you can see the minutes after the stimulation. So at point 0 you can see that the radioactive label grains, they are present in the rough endoplasmic reticulum, and after some times they start coming into the Golgi body. Later to that they are in the condensing vacuole, and then they are in the zymogen granules, and they come out into the pancreatic ducts, the lumen, sorry. How the secretion occurs, how the release of the pancreatic enzymes occurs through the pancreatic acinar cells is, it is by means of when you eat a meal, when the meal is eaten, there are signals which will act through your intrinsic and the extrinsic mechanisms, and there are phases of pancreatic secretion also. So the signals, they would reach, and here the main signal is the things which are causing the secretion of pancreatic enzymes. The two main signals are your vagal signals, which releases acetylcholine, and you have the hormone, that is cholecystokinin, which is released by the eye cells of the duodenum, right? So both of these mechanisms, as you can see here, they are now this is once you talk about the signal transduction pathway. So in the signal transduction pathway is that once the neurotransmitter or once the hormone has been released, it will act through the receptor depending upon the chemistry of the substance. So here these are acting through the membrane receptors, and these are G protein coupled receptors. ठीक है, तो acetylcholine का muscarinic receptor हो गया, और cholecystokinin का, this is the cholecystokinin receptor. Now both of these, they are G protein coupled receptors what do? They are acting via the phospholipase C pathway. ठीक है, तो जब एसिटाइल कोलिन कहाँ से आया? एसिटाइल कोलिन आएगा पैरासिम्पैथेटिक स्टिमुलेशन से। पैरासिम्पैथेटिक स्टिमुलेशन कहाँ से होगा? वेगस नर्व के थ्रू होगा। एसिटाइल कोलिन रिलीज हुआ, एसिटाइल कोलिन ने जी प्रोटीन कपल रिसेप्टर पे बाइंड करा। कौन सा रिसेप्टर? मस्करैनिक रिसेप्टर। ठीक है, then it is going to activate the phospholipase C, which causes the formation of diacyl glycerol and phosphatidyl inositol diphosphate, which forms inositol triphosphate. This causes release of calcium ion from the cytoplasmic store, and that cytoplasmic store is the sarcoplasmic reticulum, from where it is released. This is from the endoplasmic reticulum, sorry. So from here it is released, the calcium ion is released. Another is it forms diacyl glycerol. So diacyl glycerol will activate the protein kinase C, and this calcium which is released from endoplasmic reticulum, it also binds to the calmodulin, and it causes the action of प्रोटीन काइनेज एंड फॉस्फेटेजेस, राइट? ठीक है, तो फिर से बताती हूँ, दिस इज द सिग्नल ट्रांसडक्शन पाथवे फॉर सिक्रीशन ऑफ पैंक्रियाटिक एंजाइम्स बाय द एसिनर सेल्स। ठीक है, एसिनर सेल से रिलीज होते हैं पैंक्रियाटिक एंजाइम्स। उसका सिग्नल मेन, उसका स्टिमुलेशन कहाँ से आ रहा है? वेगस से और कोलिसिस्टोकाइनिन से, राइट? कोलिसिस्टोकाइनिन कहाँ से आ रहा है? duodenum से। duodenum में कहाँ से? आई cells of the duodenum. They act on the membrane receptor. Now this is the basolateral side of the acini, this is the luminal side of the acini. So they bind to the G protein coupled receptor, activate phospholipase C, which in turn causes the increase in calcium ions, and this increase in calcium ion further causes the release of pancreatic enzymes from the zymogen granules by the process of exocytosis. Second इसमें क्या हो रहा है? Second है the vasoactive intestinal polypeptide and secretin. They are also acting through the G protein coupled receptors, but they cause activation of adenyl cyclase, which causes increase in cyclic AMP, the activation of the protein kinase A, and this also leads to release of pancreatic enzymes by exocytosis. So altered phosphorylation of structural and regulatory proteins leads to insertion of vesicles and thus protein secretion. ठीक है, signal transduction pathway for secretion of pancreatic enzymes occurs by acetylcholine, cholecystokinin, VIP, and secretin. Main are these two. Cause increase in calcium ion, which cause exocytosis from the zymogen granules. Second part in pancreatic secretion is the secretion of the fluid portion. In the fluid portion, we are concerned about the bicarbonate secretion. Bicarbonate secretion, it occurs by the ductal cells. ठीक है, तो ये आपको एक ductal cell दिखा रहा है, pancreatic ductal cell है. This is just a model of how the pancreatic secretion occurs. So this is the basolateral side, this is the luminal side, right? So here you have the basic step in this is that there is exchange of chloride and bicarbonate ion which is occurring on the luminal side of the ductal cell. ठीक है, अब ये bicarbonate lumen में आ रहा है, तो ये कहाँ से आ रहा है? ये bicarbonate आएगा या तो कार्बन डाइऑक्साइड और वाटर के कॉम्बिनेशन से आ रहा है, और या ये आ रहा है थ्रू the symport mechanism of sodium and bicarbonate, which is occurring on the basolateral side of the pancreatic duct cell, right? So you have that the carbon dioxide combines with water in the presence of carbonic anhydrase to form carbonic acid, which will dissociate into bicarbonate and hydrogen ion. This bicarbonate will come into the lumen by chloride bicarbonate exchange. Now, this chloride bicarbonate, now chloride, you know that the ductal cell is it is negative with respect to the extracellular fluid. So chloride is flowing against its electrical gradient, and so energy is required, right? And here also, because bicarbonate is more in the lumen, so it is also flowing against its gradient. So again, energy is required, and this energy is provided by the operation of the sodium potassium ATPase pump. So it's a kind of secondary active transport mechanism. Another thing which happens is that some of the bicarbonate, as I told you, comes by the sodium bicarbonate symport mechanism. And this is your chloride, and whatever chloride is entered can be recycled. So this is known as chloride recycling. And this maintains the gradients. Potassium comes out into the interstitial fluid through the potassium leak channels. So bicarbonate is exchanged for chloride, and secretin increases this rate of exchange. Now it comes on to, so this was a model of it. Now this is showing you the details of how the bicarbonate is secreted in the lumen, right? So here you have the lumen of the duct, and this is the basolateral side. So first thing is that bicarbonate secretion occurs via an exchanger, and that exchanger is the chloride, and the two bicarbonate ions come out. So for chloride, each chloride which is coming inside, there are two bicarbonate ions which are coming out. So this is chloride bicarbonate exchanger, and this is the main step in the formation of bicarbonate ion. Where does this bicarbonate come from? This bicarbonate, some of the bicarbonate, as I told you, directly enters via the sodium bicarbonate co-transport, which is occurring on the basolateral side. Some of it comes through, most of it in fact is formed by or generated within the cytoplasm by the action of carbon dioxide and hydroxyl ion, by the action in the presence of carbonic anhydrase enzyme. So the carbon dioxide diffuses, or it can be formed by the metabolic products, metabolism which is occurring within the cell. And where does hydroxyl ion comes from? Hydroxyl ion comes from the dissociation of water. So water dissociates into hydrogen ion and hydroxyl ion. So carbon dioxide combines with hydroxyl ion in the presence of carbonic anhydrase enzyme to form bicarbonate ion, which is expelled out by an exchanger process. Hydroxyl ion needed comes from the splitting of water, and this hydrogen ion which is formed here, it comes out by means of a hydrogen pump, or it can come out by means of a sodium hydrogen exchanger. Secretin is the most powerful stimulus for bicarbonate secretion. It acts via the cyclic AMP mechanism, and this cyclic AMP mechanism in turn leads to insertion of these chloride channels which are present here, and these channels are known as cystic fibrosis transmembrane conductance regulator, right? So these are cystic fibrosis transmembrane conductance regulator. These are very important channels, because if there is a deficiency of these channels, then what will happen is that the chloride ion will not be recycled, and once the chloride ions will not come out, and once they are not coming out, the bicarbonate cannot be extruded out, because you require the chloride ions for chloride bicarbonate exchange. Acetylcholine also stimulates bicarbonate secretion. It does so by the activation of the protein kinase C and leads to increase in the calcium ions, which in turn causes increase in the secretion of bicarbonate ions. So this is showing you the CFTR, or the cystic fibrosis transmembrane conductance regulator, which helps in the extrusion of chloride ion, and so it maintains a luminal content of chloride within the it maintains the chloride concentration within the lumen. Why is it important? Because the bicarbonate ion can come into the lumen only by chloride bicarbonate exchanger, and अगर इसका यहाँ पे क्लोराइड का concentration कम हो जाएगा तो bicarbonate का secretion कम हो जाएगा, right? एंड रिसाइकलिंग कैसे हो रही है क्लोराइड की? क्लोराइड अंदर आ रहा है, बाइकार्बोनेट बाहर आ रहा है, ठीक है? So I think it is clear to everyone, right? So this is just a few notes of it. Carbon dioxide combines with water in presence of carbonic anhydrase, dissociates, enters by secondary active transport, hydrogen transported through apical membrane by counter transport mechanism. This is established by sodium potassium ATPase pump. Bicarbonate moves out of cell in exchange for chloride against an electrochemical gradient, and rate of bicarbonate secretion is dependent upon luminal chloride concentration. I have already explained to you. This can again come to you as what will happen and why to a rate of bicarbonate secretion in pancreas if the person is suffering from cystic fibrosis. सो सिस्टिक फाइब्रोसिस में क्या होगा कि CFTR जो चैनल्स है वो हेरिडिटरी डिजीज होती है, उसमें उनका फंक्शनिंग लो होती है या कम होती है. So this is just showing you the location of important transport processes involved in the pancreatic secretion. So you have in the acini, it is primarily the proteins, and in the duct, it is primarily the bicarbonate secretion. Right? So what will happen to the ionic composition of pancreatic juice if the secretion rate is low or if the secretion rate is high? So low secretion, this is showing you the composition of the pancreatic juice. Now you can see this is on the x-axis is the flow rate, and on the y-axis is the concentration of the ions. So when the secretion rate is low, bicarbonate ion concentration is low, chloride concentration is high. When the secretion rate is high, because bicarbonate is secreted and chloride bicarbonate exchange occurs, so the chloride concentration decreases. Sodium and potassium concentrations remain the same because the gradient is being maintained. And this juice is isotonic, so there is the isotonicity is maintained by the osmosis of water. Right? Time course of pancreatic secretion during fasting and feeding. So the pancreatic secretion will occur in the interdigestive period also, and it will occur in response to a meal, right? So that is basically what is meant by the time course of pancreatic secretion during fasting and feeding. Fasting matlab interdigestive period, or feeding matlab when you have taken a meal. I have not dealt with the migrating motor complexes, but migrating motor complex I'll deal with when I'm dealing with the motility of the GIT, right? So basically migrating motor complexes, they are the GI movements which occur during the interdigestive period. Interdigestive period is when you have taken a meal, so 90 minutes post meal, the migrating motor complexes, they start occurring. It has 4 phases. So as you see from here is that it is showing you the interdigestive output of secretory products by the pancreas. It varies cyclically in rough synchrony with 4 phases of motor activity. That is, in the interdigestive period, you have migrating motor complexes. So During the migrating motor complexes, the highest motility is during the phase 3. और यहाँ पर अगर आप देख रहे हो तो आउटपुट एंजाइम का भी हाईएस्ट मोटिलिटी जब होती है तभी होता है, राइट? In the phase 1, if you see, it is at the lowest levels, increases during the phase 2, reaches a peak and then again starts to decline in phase 4 and reaches the lowest level at the beginning of phase 1. So this is the interdigestive output of the pancreatic juice and the enzymes it contains. As soon as a person takes a meal, you can see that there is a sharp increase in the output of the enzymes, right? So that is the fed state. Feeding causes a massive and sustained increase in the trypsin release and switches the small intestinal motility to the fed state. So here you can see that the increase, there is an increase in the secretion of trypsin. And as you know, the trypsin causes the conversion, the activation of other enzymes. So during the interdigestive period, trypsin output is less, and as soon as a person takes a meal, there is a sharp increase in the output of trypsin. So in the pancreatic juice, or in the pancreatic secretion, I have told you about the composition of the pancreatic juice. It comprises of water and it comprises of solutes. Solutes made comprises of organic and inorganic contents. In the organic contents, it comprises of various kinds of enzymes. In the inorganic contents, it is mainly alkaline, so it contains bicarbonate ion. The enzymes, they are secreted by the acinar cells and they are secreted by the exocytosis of the zymogen granules, from the zymogen granules. The alkaline secretion is from the bicarbonate secretion is from the ductal cells, and I have already described you the mechanism in which the key step is your chloride bicarbonate exchanger. So now we come on to, and of course I told you about what would be the effect of rate of secretion on the pancreatic juice composition. So now we come on to the regulation of pancreatic secretion. So you know about the composition of pancreatic juice, you know about the mechanism of pancreatic juice secretion. Third part is the regulation of pancreatic secretion. ये भी long question आ सकता है या ये problem based question भी आ सकता है, okay? Or it can come as a short note. So regulation of pancreatic secretion. Secretion of fluid and bicarbonate is mainly dependent upon the amount of acid which is entering the duodenum. जितना acidic होगा उतना ज़्यादा alkaline pancreatic juice secrete होगा, उतना ज़्यादा bicarbonate secrete होगा. Secretion of enzymes is mainly dependent upon the amount of fat and protein which is entering the duodenum. So the content of food, the acidity of food will determine what kind of pancreatic juice secretion is going to occur. अगर दोनों चीजें हैं तो enzymes भी secrete होंगे और bicarbonate भी secrete होगा. So enzyme secretion is mainly by the vagovagal reflexes and by the cholecystokinin hormone, and the bicarbonate secretion is by the secretin. Okay. So this is showing you the acid from the stomach, the acid content, the acidic contents of the stomach as they reach the duodenum, they cause release of secretin from the duodenal cells, and fats and amino acids, they will cause release of the cholecystokinin. So depending upon the acidity and depending upon the food products, the hormones would be secreted. They will come into the blood circulation from where they will reach the pancreas. In the pancreas, the secretin will cause release of copious amount of pancreatic fluid and bicarbonate from the pancreatic ductal cells, and the cholecystokinin will cause the release of enzymes from the pancreatic acinar cells. In addition to that, you also have the neural control on pancreatic secretion, which is coming from the vagus. Vagus is a parasympathetic nerve, so it causes releases. Vagus stimulation causes a release of enzymes into the acini. So rate of pancreatic, this is just showing you that how the rate of pancreatic secretion varies with different kinds of contents which are there in the duodenum. So you can see that if there is, it is an acidic kind, highly acidic content, it will cause copious secretion of water and bicarbonate, but less secretion of enzymes. If it contains both, then it will secrete both the water and bicarbonate as well as enzymes, and the protein digestion products will cause a higher secretion of enzymes and lesser secretion of water and sodium bicarbonate. Okay, so again and again I'm repeating this because this is very important. So regulation of pancreatic secretion occurs by two mechanisms. You have the neural mechanism, which is mediated by the vagus nerve, which causes the secretion of primarily enzymes, and it is mediated by hormonal mechanisms. In the hormonal mechanisms, you have two hormones. One is the cholecystokinin, second one is the secretin. Secretin is released in response to the acid in the duodenum. Cholecystokinin is released in response to the fats and proteins which are present in the chyme. So they cause secretion of alkaline watery pancreatic juice and enzyme rich pancreatic juice respectively. Right? So increased acid from stomach causes increase in secretion of secretin from small intestine, the S cells of the small intestine, increased plasma levels of secretin, which acts via the signal transduction mechanism to cause increase in the bicarbonate secretion from the pancreatic ductal cells, increased flow of bicarbonate into the small intestine, neutralization of the intestinal acid, which has a negative feedback effect on the secretin secretion. Increased intestinal fatty acids and amino acids leads to increase in secretion of cholecystokinin from I cells of the small intestine, causes increase in the plasma. Cholecystokinin causes increased secretion of enzymes from pancreatic acini, increase of flow of enzymes into small intestine, increased digestion of fats and proteins. Okay, so this is showing you the hormonal regulation of pancreatic juice secretion. This is the bicarbonate secretion, and this is showing you the enzymatic secretion. Bicarbonate secretion ductal cells में होगा, क्लोराइड बाइकार्बोनेट एक्सचेंजर से होगा. बाइकार्बोनेट कहाँ से आएगा? बाइकार्बोनेट आएगा या तो उसका symport होगा through sodium bicarbonate symport mechanism से, or it would be formed within the cytoplasm in the presence of carbonic anhydrase, right? और enzymes कहाँ होंगे? acinar cells में होंगे, protein synthesis mechanism से होंगे, और constituted या regulated pathway से release होंगे into the lumen of the pancreas, right? So this is now showing you what will be the effect of duodenal pH on the secretion of the secretin, right? So pancreatic bicarbonate output responds to duodenal acidification. Pancreatic bicarbonate output कैसे बढ़ेगा? secretin के उससे बढ़ेगा. secretin कब बढ़ेगा? secretin release होगा जब luminal pH would be less than 4.5. This luminal pH here we are talking about the duodenal luminal pH. Okay. When the pH is below 3 or when the pH is equal to 3, it is the secretin release will be maximum. तो यहाँ पे अगर आप देखो कि इसका this is the duodenal pH. तो जैसे जैसे इसका pH कम हो रहा है वैसे वैसे सिक्रीशन ऑफ सिक्रिटिन इंक्रीज होगा और जैसे जैसे सिक्रिटिन का इंक्रीज होगा रिलीज वैसे वैसे bicarbonate output from the pancreas will increase. So HCO3 output is used as an index of secretin release. Now this is important because when I'm telling you about the pancreatic function test, तो उसमें एक stimulation test होता है which is known as the secretin test, right? So basically उसमें ये देखा जाता है कि secretin जब इंजेक्ट करते हैं सब्जेक्ट में तो is it leading to an increase in bicarbonate ion secretion from the pancreas or not? If it is not leading to, or if it is not leading to a sufficient increase, then you label it as a pancreatic insufficiency, or it could be because of pancreatitis. It can be chronic acute pancreatitis or any other disorder of the pancreas. During meal, the pH rarely goes below 3.5 or 4 because when I'm talking about the motility of the GIT, I'll also tell you about how the rate of gastric emptying is being regulated by the duodenal pH, right? So during a meal, the pH of the duodenum rarely goes below 3.5 or 4. Now we come on to another part of pancreatic secretion, that is the phases of pancreatic secretion and their regulation. ठीक है, तो जैसे आपका gastric में होता है, gastric secretion में I told you about 3 phases, the cephalic, the gastric and the intestinal phase. So also in case of the pancreatic secretion, you have the cephalic, gastric and the intestinal phase. Cephalic is when the food is present in the mouth. Gastric is when it is present in the stomach, and intestinal is when the food reaches the small intestine, right? So cephalic contributes about 20% to the pancreatic juice secretion. Gastric phase is about 5 to 10%, and rest of it is from the intestinal phase of pancreatic juice secretion occurs. Why is the cephalic and gastric phase important? Cephalic and gastric phase is important because as soon as you see food or you eat food or you smell the thought of food, whatever, it causes an increase in the pancreatic juice secretion, so that when the food finally reaches the small intestine, it does not waste time in causing the digestion of the food products and causing the neutralization of the acidic chyme. तो वो kind of prepare करता है cephalic और gastric phase. Prepare किसको करता है? It is preparing the small intestine to receive the acidic chyme, so that once it actually receives the acidic chyme, it is already having a buffer within itself, so that it can start neutralizing the acidity of the chyme and it can start digesting the food items which are coming into the small intestine. ठीक है, तो इसलिए भी cephalic और gastric phase की importance है कि वो prepare कर रहा है small intestine को to receive the acidic chyme. Stimulus क्या है? Conditioned reflex initiated by taste, smell, thought of food. Unconditioned reflex initiated by taste of food in the mouth. You must be knowing about a conditioned and an unconditioned reflex by now. So gastric is and the cephalic phase is mediated by neural mechanisms, that is by the vagus. So it causes little secretion of pancreatic enzymes and bicarbonate. Gastric is by distension of the stomach or by the protein digestion products or low pH of chyme in the duodenum. It is both neurally mediated as well as hormonally mediated. And the final is your intestinal phase of secretion, which occurs, the stimulus is food in the small intestine and amino acids and peptides in the chyme in duodenum. Again, it is both hormonally as well as neurally mediated. ठीक है, तो अब ये दिखा रहा है आपको how the cephalic and the gastric phases of pancreatic juice secretion occurs. So this is the cephalic phase, the sight, the taste, the smell of food. It is mainly neurally mediated. So the signals, they pass to the dorsal motor nucleus of the vagus nerve, and this causes the release of you have acetylcholine is released, which acts on the pancreatic acinar cells through the muscarinic receptors. And last time, if you remember, I told you that it is also stimulating the G cells, and these G cells are present in the antral mucosa. And here what is happening is that it is being stimulated by gastrin releasing polypeptide. So it causes release of gastrin, which further causes the stimulation of cholecystokinin and cholecystokinin acetylcholine. Both of these cause secretion of pancreatic juice, which is rich in enzyme. So here you can see that it is causing a secretion which is rich in enzymes, and it also contains water, right? Then you have the stomach, that is the gastric phase, also by the same mechanism you can see. And more important here is of course this is also acting through this, and it has led to and this acetylcholine has also led to release of the bicarbonate through the pancreatic duct. So this is also mediated by the vagal mechanism. Then the intestinal phase, which is contributing 70 to 80% of the pancreatic secretion. If you start from here, there is the hydrogen ion which is present. So where is it coming from? This is showing you the duodenum. So duodenum में कहाँ से आ रहा है? It is coming from the stomach. It reaches the duodenum. Stomach में HCl secrete हुआ, और यहाँ पे इसका कंट्रोल्ड एम्प्टीइंग ऑफ स्टमक हुआ, जिससे एसिडिक काइम डियोडेनम में आया. Once the acidic chyme is there in the duodenum, what will it cause? It will cause stimulation of the S cells in the duodenal mucosa, and this will secrete the hormone, that is secretin, and this secretin will, through the bloodstream, it will come to the pancreatic ductal cells, act on the secretin receptor and cause the release of bicarbonate rich secretion, which I have already told you the mechanism of it, right? दूसरा क्या है? दूसरा इसमें है, you have the protein and the lipid breakdown products. They will stimulate the I cells in the duodenum, cause release of cholecystokinin. It is also mediated by the neural mechanism. Also, it will lead to release of cholecystokinin, and then this will act on the acinar cells. The cholecystokinin will act on the acinar cells, and it will cause release of the enzymes. Okay. So now we come on to the applied aspects of what happens if there is a dysfunction of the exocrine pancreas. So you can see that pancreas is releasing enzymes which are required for all three categories of nutrients. So अगर pancreatic function derange होगा तो क्या होगा कि digestion of nutrients will be hampered. Once the digestion of nutrients will be hampered, so no matter that you are taking in food, but that food is not being digested. Once it is not being digested, where will it go? It will come out through the stool. So जो initially दिखाया था the slide, the video which I showed, in that it also showed you that there would be certain symptoms which are occurring. So they can be bloating, there can be flatulence, there can be excretion of oily sticky stool, which is known as steatorrhea, right? So all this occurs because there is deficiency of pancreatic enzymes. And why this can occur? It can occur because of the autodigestion which is occurring. Autodigestion क्यों हो रहा है? क्योंकि pancreatic enzymes can get activated within the pancreas. There can be a deficiency of trypsin inhibitor, which leads to the activation of pancreatic enzymes within the pancreas, which causes autodigestion and leads to inflammation known as pancreatitis. or because of malignancy, the pancreas had to be removed. Again, this might lead to a decrease in the normal amounts of enzymes. So what is pancreatitis? It means inflammation of pancreas. I have already told you about the autodigestion which can occur. Circulating levels of digestive enzymes rise markedly, and there can be an increase in the serum amylase or lipase concentrations which have diagnostic value. Right? Chronic pancreatitis, if it occurs over a long period of time, then it's known as chronic pancreatitis. So if you have to differentiate between acute and chronic pancreatitis, it is primarily that acute pancreatitis can revert back to normal, but in a patient of chronic pancreatitis, there is a permanent damage to the pancreatic tissues. So this is some the symptoms. There is upper abdominal pain. The pain can radiate to the back. It feels worse after eating because then there would be more secretion, more acidity which would be occurring. There can be fever because inflammation is there, or fever can lead to tachycardia. There can be nausea, vomiting. So all these are GI symptoms which are occurring along with the acute pancreatitis symptoms. Causes, this is just a mnemonic, pancreatitis. So it is posterior, means it's situated posterior to the stomach. Alcohol is one of the major causes of pancreatitis. And neoplasm means malignancy, that is cancer. Cholelithiasis means stone, the gallbladder stones. Treatment means it can be induced because it can be caused because of drugs. ERCP is a it can be a diagnostic procedure as well as a therapeutic procedure. It can damage the lead to trauma. So all these can lead to inflammation of the pancreas. Infection, the mumps, it can lead to acute pancreatitis. And so these are just a few causes of how the inflammation of pancreas is occurring. Chronic pancreatitis can be hereditary causes. It can be because of cystic fibrosis where the chloride channels, they are defective. It can be autoimmune. It can the acute pancreatitis can progress to chronic pancreatitis. We can have intermittent bouts of acute pancreatitis, which finally leads to chronic pancreatitis. And there can be one of the other causes, major causes, is alcohol and smoking. So again, if you remember from the video, it said that consult your doctor, quit smoking, quit alcohol. And this is showing you that there is a stone, and this stone, it causes a this stone is a gallbladder stone which may have come out through the common bile duct, and it can there can be a backflow of this stone, so it's obstructing the main pancreatic duct, which in turn causes an obstruction in the outflow of pancreatic juice, and this in turn can lead to inflammation of the pancreas. Right? So again, started with the video. So before we move on to the pancreatic function test, I'll just show you another video.
Acute pancreatitis. Acute pancreatitis is the sudden inflammation of the pancreas. It can be very painful and usually means a stay in the hospital. About 5% of cases are life-threatening, usually when other organs are involved. The pancreas is a digestive system organ that has two important functions. It produces enzymes to break down food in the digestive tract, as well as hormones that regulate blood sugar. In acute pancreatitis, the enzymes used to break down food become activated before they leave the pancreas. These enzymes are so powerful that they start to attack and digest the pancreatic tissue. This process is called autodigestion. The most common causes of acute pancreatitis are heavy alcohol use and gallstones. Other less common causes include abdominal trauma, medications, infections, tumors, and genetic or anatomical variants. High triglycerides or high levels of calcium in the blood are also linked to acute pancreatitis. In some rare cases, the cause is never discovered. Attacks of acute pancreatitis are usually sudden and characterized by intense pain in the center of the upper abdomen, between the belly button and the chest. The pain radiates to the back. Sometimes the pain can be on the left or right side, or even lower down in the belly. Most people also have nausea and vomiting, and in some cases, fever. Blood tests for pancreatic enzymes can diagnose acute pancreatitis. The pancreatic enzymes that are typically elevated when patients have acute pancreatitis are called amylase and lipase. Diagnosis is usually confirmed by a CT scan. On occasion, MRI or ultrasound may be used. The radiologist will look to see if the pancreas is swollen or if there is abnormal fluid around it. Most people who develop acute pancreatitis are out of the hospital in a few days. However, about 1 in 10 cases are serious enough to affect other organs like the kidneys and lungs, and may require a longer stay in the hospital. Sometimes patients have to be treated in the intensive care unit. In very severe cases, surgery may be required to remove inflamed parts of the pancreas. If the cause of acute pancreatitis was related to gallstones, the gallbladder is removed surgically. As well, in some patients, the pancreas becomes so damaged that it no longer functions properly to make digestive enzymes. This is called pancreatic insufficiency. Following an episode of acute pancreatitis, patients are advised to avoid alcohol and tobacco consumption, high-fat foods and triglycerides, and medications that can put stress on the pancreas. As well, patients are encouraged to stay well hydrated and to eat a varied and healthy diet that is rich in fruits and vegetables.
So,
acute pancreatitis.
So this was just it was just a recapitulation of whatever I had just told you. So now you must have got a very good idea about why your pancreas are so important and why it is difficult to diagnose a pancreatic disorder, right? But still we have a few things which are available which can help us in diagnosing a pancreatic disorder, right? So this is just another disorder which is cystic fibrosis, where there is a lack of chloride transporter at the apical membrane, and that I have already described when I was telling you about the mechanism of pancreatic secretion. Okay. So pancreatic function tests is how to assess any abnormality of the pancreas. You want to see whether you want to evaluate whether the pancreas are functioning normally or not, and you also want to detect the abnormality if any is present. So you have they are largely divided into, you can divide them into the pancreatic function test for diagnosing disease of exocrine pancreas, or you want to diagnose exocrine pancreatic insufficiency, right? So there you have a few enzymes, as the video also showed. You have the estimation of serum amylase levels or serum lipase levels. So you can do a sweat chloride test if there is a hereditary predisposition, and from the history you'll come to know that the person might be having cystic fibrosis. So in that cases, the sweat chloride test is also useful. For diagnosing exocrine pancreatic insufficiencies, there are the direct tests and the indirect tests. These are basically the stimulation, the direct tests. These are the stimulation tests. You have a long list of tests, but at your level, you should be knowing these two. That is the secretin test and the combined secretin and cholecystokinin test, right? In the indirect test, It is primarily that we are indirectly estimating whether the pancreas is functioning properly or not. So in that you have the Lund test, and in which it is basically stimulated by a test meal, and then you see for the assessment of how much trypsin is there within the pancreatic juice. Other tests are the fecal fat excretion test, fecal nitrogen excretion test, fecal elastase excretion test. So these are basically testing for how much of you are testing it in the fecal matter. You are testing for these things and assessing for the exocrine pancreatic insufficiency. And last test in this is the dual label Schilling test, which is basically we are testing for the vitamin B12 absorption and seeing whether it is there or not. And if there is pancreatic insufficiency, the absorption of vitamin B12 is also abnormal, right? So now coming on to each test one by one. Test for exocrine pancreas, you estimate the levels of serum amylase and serum lipase levels. Now, both these are the serum amylase is basically coming from the pancreas. A little bit of amylase is of salivary origin. So if the serum amylase level is increased to more than or equal to 3 times its normal value, it has kind of diagnostic value for acute pancreatitis. ठीक है, अगर serum amylase और lipase की level more than 3 times है normal से, तो वो point करता है towards acute pancreatitis. But इसमें problem क्या है? इसमें problem ये है कि जो serum amylase levels है, suppose a person is having an attack of acute pancreatitis, right? So this serum amylase level उस समय तो increased होगा, लेकिन अगर वो 1-2 दिन बाद आएगा, so it starts decreasing. So you might not be able to pick up the increased levels of serum amylase, because serum amylase tends to come down to normal values within 2 to 3 days. But serum lipase जो है वो increased रहता है for a longer duration, maybe 1 to 2 weeks, right? And as I told you, sweat chloride is particularly useful in cystic fibrosis. What is more important for you is the exocrine pancreatic insufficiency tests, which are direct or indirect tests, right? So these are the most common causes of EPI are chronic pancreatitis and cystic fibrosis. I told you that 90% of the derangement होगा तो usually manifest karta hai. So to get the pancreatic function test done is not easy, because they are not easy to do also, right? So it is very difficult to diagnose EPI by indirect tests, and it is equally difficult to diagnose by direct tests because the procedure is highly skilled. So how do we perform tests for exocrine pancreatic insufficiency? In this, what is done is that in the direct test, oro or a nasoduodenal intubation is done for aspirating pancreatic secretion. तो जो भी आप टेस्ट करते हो डायरेक्ट टेस्ट, उसमें क्या करते हैं कि पहले इंट्यूबेट करते हैं पेशेंट को, उसमें एक डबल ल्यूमेन रेडियो ओपेक ट्यूब डालते हैं. नाउ दीज डेज एंडोस्कोपी इज आल्सो अवेलेबल, सो एंडोस्कोपिक गाइडेड tubes can be put, which have 2 sets of holes. One is for the duodenum and another one is for the gastric aspiration. तो जो duodenum से आप aspirate ले रहे हो वो basically pancreatic उसमें juice होगा, right? So these days fiber optic catheters are available, which can you can view under direct vision into the pancreatic duct. But mind it, this is not a very simple procedure. It requires a lot of expertise. So some of you who intend to become gastroenterologists, you would be specializing in these kinds of testing and these kind of procedures, which is pretty difficult. And in our college also, I think Pant has it in the gastroenterology department. So how do we basically intubation is done is this tube is passed through the nose or it could be passed through the mouth. It is a double lumen tube. So इसमें tube में markings होती हैं which tell you about how far it has reached, so you get an idea about whether it is in the stomach or it has reached the duodenum. And here you can see an endoscope can be passed through the mouth. So the tube is being passed through the nose and the endoscope is being passed through the mouth, and you can visualize where exactly the lumen of the two lumens are. So one is going into the stomach, another one is into the duodenum. Okay. So this is showing you that this is being passed through the nasal route, and there is an endoscope, and then you can visualize endoscopically whether the tube has reached the stomach or it has reached the duodenum. So once it is in place, then those stimulation tests are done and the secretions would be aspirated out from these tubes. So in the secretin test, secretin, as you know, is a hormone which stimulates the ductal cells. It is used to measure the secretory capacity of the ductal cells. After overnight fasting, the duodenal and gastric contents are aspirated in the morning. तो इससे पहले जो आपको slides दिखाई थी, first इसमें instruction क्या होगा patient को कि अगर वो patient आपका ये स्टिमुलेशन टेस्ट के लिए आ रहा है तो आप उसको इंस्ट्रक्ट करोगे कि उसको आफ्टर he has to report to the lab or he has to report to the to where the procedure is being done, that he has to come empty stomach, overnight fasting, and then you put in this double lumen tube and one end into the stomach and another into the duodenum. You aspirate those contents in the morning, and then an IV infusion of secretin is given in this dose, and you start collecting the duodenal aspirate at an interval of 10 minutes over the next 80 minutes. So serial samples are taken, and what is the sample? Sample is the duodenal aspirate. And these contents are examined for the volume, the pH, the bicarbonate concentration, and the bicarbonate output. These are the normal values. The volume should be more than 2 milliliters per kg in 80 minutes. Bicarbonate concentration should be more than 80 milliequivalents per liter. Bicarbonate output should be more than 10 milliequivalents per liter in 30 minutes. And if there is chronic pancreatitis, then the secretory activity of the ductal cells would be decreased. So this is how it is done. So here basically it's the duodenum, and this is showing you that the duodenal juice is being collected from 10 to 80 minutes, and then it is subjected to the following things are being examined, in which you are examining the volume, the pH, bicarbonate concentration, and the bicarbonate output. Okay? On similar lines, you also do the combined secretin and the CCK test. It is done to evaluate the secretory capacity of both ductal and the acinar cells. So first, the secretin test is performed. Then you give CCK is given IV. Whole process is repeated, and the curves for the normal values of volume, bicarbonate, and enzyme levels is obtained by this test. Abnormalities can be detected if there is a mild pancreatic damage. There is dissociation between the bicarbonate and enzyme output. With advanced damage, both would be affected. This helps to differentiate patients with steatorrhea due to intestinal malabsorption, in which the test will be normal, from that due to chronic pancreatitis, in which there will be decreased secretion of enzymes. So steatorrhea क्या होता है? Steatorrhea is basically those bulky, oily stools which are difficult to flush, and it can if the person is complaining of steatorrhea, says he has bulky stools, foul smelling stools, so you think about malabsorption, which can be because of intestinal malabsorption, or you can also think about in the differential diagnosis chronic pancreatitis. So kaise karoge? Of course you have other tests also, but one of them is this, which is not so easy, not so easily performed also. So this will help you in differentiating whether it is because of intestinal malabsorption or chronic pancreatitis. This is showing you the normal curves of combined secretin cholecystokinin test. So here you have the volume of pancreatic juice, here you have the bicarbonate concentration, and here you have the amylase level. So here it is showing you the time in minutes when the IV injection was done, and this is showing you the flow. So you see here, this is the cholecystokinin and this is the secretin curve. If you see here, on injection, rate increases. This would be the volume increases, the flow rate increases, and the bicarbonate is more as when the secretin injection is given, and the enzyme increases in response to the cholecystokinin pancreazyme. Right. So these are the normal curves which occur during a combined secretin cholecystokinin stimulation test. ये important है क्योंकि ये आपका problem based learning में भी आ सकता है और ये आपका question भी आ सकता है in your question paper. Indirect tests for exocrine pancreatic insufficiency, you measure the fecal fat or you measure the fecal elastase. Patient is placed on a diet having 100 grams of fat per day. Stool is collected and fat excretion is measured daily for 3 days. Normal persons, they excrete less than 7% of the ingested fat. In EPI, excretion of fat would be more than 20%. Fecal elastase is excretion of less than 200 micrograms of elastase per gram of stool indicates EPI. So this is secreted by the pancreas, और अगर इसका concentration कम है stools में, so it indicates in exocrine pancreatic insufficiency. These are indirect tests. So I'll just show you a video of ERCP also.
If you've had pain in your upper abdomen or lost weight without trying, your healthcare provider might want to do a test called ERCP. ERCP stands for Endoscopic Retrograde Cholangiopancreatography. ERCP is used to diagnose and treat problems in your liver, gallbladder, bile ducts, and pancreas. All of these organs help with digestion. Your liver is a large organ in the upper right side of your abdomen. Your liver has more than 500 different functions. One of the things it does is make a substance called bile. Bile helps break down foods to digest them. A small organ near the liver called the gallbladder stores the bile until it's needed. Tubes called bile ducts carry the bile from your liver to your gallbladder and small intestine. They are sometimes called the biliary tree. Your pancreas is a large gland that also helps with digestion. It makes chemicals that are sent into the small intestine through a duct. ERCP can look at all of these organs and ducts. The procedure. Depending on the time of your procedure, you will be told to not eat or drink several hours before your procedure. Your stomach and duodenum must be empty for the procedure to be accurate and safe. Also, tell your healthcare provider if you have any allergies, especially to iodine. Iodine is in the special dye used during ERCP. When it's time for your procedure, you may be given medication to help you relax or sleep. This is called sedation. This medication is usually given through an IV line put in a vein in your arm or hand. Your throat may be numbed with a spray or liquid, and you'll be given a small plastic guard to protect your teeth. You will be positioned on your left side on an examining table in an X-ray room. An endoscope is a long, flexible tube that contains a tiny light and camera. You swallow the endoscope. It is then guided through your esophagus, your stomach, and the first part of your small intestine. You then turn to lie flat on your stomach. A small tube is passed through the scope. A special dye is sent through the tube. This is so the ducts and organs can be seen on an X-ray. The insides of these organs are checked for any problems. The exam might show a gallstone or narrowing of the ducts. If so, tools can be put through the scope to remove a stone or fix a blockage. A tissue sample, called a biopsy, may be taken for further testing. ERCP takes 30 minutes to 2 hours. After the procedure, you will not be able to leave until the sedative wears off. A family member or friend will need to drive you home. If any kind of treatment is done during ERCP, such as removing a gallstone, you may need to stay in the hospital.
So that showed you how this ERCP is done. So next time when I'm taking liver and gallbladder, this was just an introductory aspect of that also, because in the liver and gallbladder disorders also ERCP is being done. Okay, so I just cover up this also, intestinal secretions, not much in this. The intestinal secretions, they are the mucus is coming from the Brunner's glands, and they also secrete a large amount of alkaline mucus. Stimuli are your GI hormones, especially secretin. It also causes secretion of the small intestine, or they can be an tactile or an irritating stimulus, and it can be by means of parasympathetic stimulation also. This is just giving you the functions and the composition of the small intestinal secretion. You have the enzymes which are present here. So there are a number of enzymes which are present in the small intestinal secretion, which will help in the final digestion of the food products, and absorption will also occur within the small intestine. So that completes the small intestine, and you have large intestine. This is just, everything is given in your books. So this is just large intestine has also an alkaline secretion and vitamin B and K absorption made from bacterial flora in the colon, and it also secretes mucus for protection, lubrication of fecal matter, right? So that completes the pancreatic secretion, the intestinal secretion. And any queries, if you have, you can convey it through your CRs to me. I just try to, I had made a quiz. I don't know whether I'll be able to actually launch it. Can you see the poll? Okay, so have you, I think I'll close this poll now. What is the question? Which of the following is not true regarding pancreatic juice? So as I can see, 46% have voted for A, 11% have voted for B, 34% for C, and 7% for D. क्या है इसका आंसर? Answer is A. I have to learn this. I still don't know how to launch a poll. I had made a few more questions, but let's see. So any questions you have, you can please ask through your CRs to me, okay? And so I'm ending this webinar as for now.